Thank you. Good afternoon, everybody. And I'm very aware that I'm standing between you and the end of the day, so we'll get straight into it. So I'm Charlotte Mills. I'm the Chief Services Officer at VMIA. We are the Victorian Government's insurer and risk advisor. Our clients range from government departments to agencies, including public health services and community service organisations. Let me just move on. We have over 4,500 clients across the Victorian public sector, and our role is much more than insurance, because we do help Victorian government entities anticipate risks, both current and emerging, so that they can make informed decisions and move forward with confidence. We use data and insights to help our clients understand why claims happen and drive harm prevention initiatives to help avoid claims in the first place. And medical indemnity is one of our key insurance products, and so patient safety is a space that we've been working in for about the last 15 years. We take notifications from hospitals. We don't take any data feeds out of hospitals, relating back to the last question that we had. So we receive around 3,000 notifications of adverse events every year. Around 500 of those are considered potentials to turn into claims, and around half of those actually do. What does that tell us? Exactly that, not a whole lot. It's not the richest picture in the world. Our claims data is never going to be on its own of the value that we need to really understand where we should be investing in patient safety. We're very reliant on working with other organisations, and something that we're going to, we want to really get better at is working on pooling data sources so that we can get the picture and make those investment decisions. In the 5 years to 2018, surgical claims made up 13% of total claims. So my question to the team was, so what? Is it going up? Is it going down? What's happening? Claims overall are going up, and surgical claims have gone up in line with that. So the proportion of claims over that 5 years has been stable from the surgical side of things. Couple of comparison points. Obstetrics has gone down in that time, maternity has gone down, and emergency has gone up. Adverse events are more likely to happen with surgical than non-surgical admissions, and one of the data points there, around 7.7 per 100 separations compared with 4.7 per 100 for non-surgical. So we do know that it is a higher risk area. As I said, our claims and notification data doesn't give a full picture, because some claims were never recognised or reported as adverse events at the time, and of course not all adverse events result in claims, either successful or unsuccessful. So it is really important that we start working together more to understand what's going on. Oh, Ursula, you've done pretty things with the slide. I hadn't realised. Financial impact of patient safety. So I'm not talking about the increased costs for us as an insurer. We're a bit lucky. We have amazing actuaries who work with us and understand trends and current situation and can predict where they think the claims will go. And from that, we can use that. We've got a lever, and it's called premium. But we don't want to keep putting premium up. That's the last thing we want. We want that money to stay in the system and be used for delivering the services that so many of you in this room deliver. We do have skin in the game when it comes to premium. It is expected that medical indemnity premium will go up around 9% every year. We set ourselves a corporate target to keep it at 6% or under, and we have managed that over the last few years. Because like I say, we don't want the money sitting in investments, getting a required rate of return for claims that are going to come up in the future. We want that money to stay in the system. But the financial impact that I'm really talking about with this slide is the additional cost of providing services when an adverse event happens. And in service management theory or Lean, Six Sigma kind of methodologies, it's often referred to as failure demand. Your demand appears to be going up in your service, but what's really happening for some of that demand is that something's happened, you've had your adverse event, and you have to do more activity to fix it and get it back to just to deliver the service. So that point between this was my objective and this is the amount of service I would have provided, something happened and then I had to provide extra service. That extra piece has long been known to be one of the best levers to pull in any kind of service to try and bring service costs down. So really that's estimations that around 15% of hospital expenditure is a direct result of adverse events. And in Australia, that would be around $2 billion annually. Whereas we know that reducing patient harm leads to significant cost savings, and cost prevention is typically lower than those additional costs are. Barriers to investment in patient safety. If you work in or run a health service or work in the sector, you'll know that there's a lot of reasons why. For us, I know one of the things that we grapple with is showing a return on investment. It's really hard to define and measure benefits. They play out over a really long period, and there's a bit of a spectrum between I want to see a return on my investment, and it's a complex system, so we're better to do something than do nothing and hope that there might be an impact. And probably the answer is somewhere in the middle, but when we are looking at securing investment into patient safety initiatives, that's one of the challenges that we have and of course patient safety can be looked at from a health service perspective and at the broader sector level, so we work up there, but I'm sure that there's lots of efforts that go on at health service level as well. Clinicians and insurers probably sound like poor bedfellows, but you know, we really only, the work we do as an insurer, we're not the experts, you are, you work in the services, you know what happens, so we want to work more with you, more with the sector organisations, and we do, but that is something that we want to keep improving. So obviously we provide a medical indemnity product. It was recently benchmarked, and it's a product that wouldn't be available in the commercial market. It is a ground-up cover, so there's no excess. We are on risk for everything that happens with medical indemnity cover. So we do, as I say, have skin in the game around helping reduce things going wrong. I'm going to move quickly just to talk about, this is sort of our journey over the last 15 years, but incentivising better patient safety, our focus has been in the maternity space. So just an example of a different way of looking at how the role that we can play. So 15 years ago, we've spent probably the last 10, 12 years supporting a number of evidence-based training initiatives, whether it's fetal surveillance or PROMPT, which is a multidisciplinary training program for basically helping teams in the maternity suite practice for when things might go wrong. So we've moved from just supporting that training to an incentivising program. So that means that eligible health services, if they train a certain percentage of their staff, they're eligible for a refund of a portion of the obstetrics component of their premium. First year out of the blocks, we had 86% of eligible health services who achieved those goals, and that resulted in a return of $2.6 million directly back to health services this year. So that's something we were really proud of. So it's a different way of looking at the role that we can play. Incentivising programs do come with risks of their own, because with an extrinsic motivator, whether it's on an individual or a group of individuals or a large group like an organisation, you always run the risk that once you take that motivator away, your system returns to where it was, or to a different sort of resting spot. So it is still progress, and we're testing different ways of getting involved with patient safety. Maternity has been a focus. As I said earlier, claims have come down in that space. Emergency has gone up. And so that's really our next focus area. We've got a large piece of work going on there now where we are pooling data. So we're not just looking at our claims data, we're going out to find what other data can we combine it with to get that rich picture of the system, and also do research on what are the evidence-based interventions that could become part of a roadmap for the future for in Victoria. And that's work we're doing, of course, with Safer Care Victoria and the department and the College of Emergency Medicine. So, we'd love to talk with you, keep talking about surgical patient safety. I'm sure it's something that's dear to everybody's heart, and it's something that we're really proud to be involved in, and we'd like to keep the conversation going. Thank you.